Okay, so we are. Please confirm that you are also online in the chat box. Hopefully this time it will not repeat. Please let me know in the chat if you are present. And we will start right away to not shed any more time. Lucas is here, Dr. Deepak is here. Thank you for being here. Let me know who's present also. Ivana, I hope it was your name. Please let me know if you're still with us. Sure, Dr. Deepak. I also have a surprise for you this time, meaning that we have more questions. I hope you received the newsletter, and in the newsletter we had actually a question of the day. So let's round up in 2 minutes to see if is anyone else connected. I'm glad that we are now live and things are going smoothly. I'll write also in the chat box. So okay. So Dr. Deepak asks us how we are doing. So Lucas, how are you doing? Okay. Then let's get started, and we will check in at every 1 or 2 vignettes to see if there are any newcomers. So today we're going to talk about vaccination schedules and acid-base algorithms. Now, one annotation, how can you enjoy the live streams and how can you get more value from the live streams? Firstly, we have the recorded ones. They are already timestamped, so you can jump through timestamps to answer the questions from the live stream, and then you can review the wrong answers with the theory slides. If you are live, you have 2 advantages. One is that you can vote for your answer, and 2 is that you can ask any questions on the topic, i.e. in this example, you can ask any question on the renal system so that you can get more value out of the live session. Okay. So, we have a 36-year-old patient that comes to the ED stating that her husband was recently diagnosed with TB. At the physical exam, there are no signs of discomfort with normal lung and cardiac auscultation. The patient's history includes a PID and a spontaneous abortion at 26 years old. A tuberculin test renders an induration diameter of 7 mm. What is the best next step? Observation for signs and symptoms. We start isoniazid for 9 months. We go for the quadruple therapy of ethambutol, rifampin, isoniazid, pyrazanamide for 2 months, and then we follow up with isoniazid and rifampin for 4 months. Or we repeat the PPD in 2 weeks. Let me know your answer in the chat box. Hello, Parth. Pleased to meet you. Okay. Now, the results are in. So we have 2 people who say that the answer is D and 2 people that say the answer is B. Can you explain how you thought the B or the D answer is correct before jumping to the answer, and how can we think on this vignette? Okay, so Parth said that he thinks that the answer is B due to the fact that the PPD that is greater than 5 mm in a close contact requires isoniazid for 9 months. Okay. So the participants who said D, what was the reasoning behind repeating the PPD in 2 weeks? So Lucas tells us that it is C. Okay, now let's discuss the right answer. The right answer is B. We start isoniazid for 9 months. The patient is positive at the tuberculin test. She's a close contact with an induration greater than 5 mm, as Parth said. Now, why do we administer isoniazid for 9 months, and why we do not go for the scheme with the 2 months of quadruple therapy and 4 months of double therapy? Well, we do not go for C because C is the treatment for active tuberculosis. This patient has no symptoms nor no signs of TB. Therefore, we start with a treatment for latent tuberculosis, namely isoniazid for 9 months. Okay. Now, let's recap a bit the important aspects of TB and tuberculin test. How we do the screening for tuberculosis? We use a PPT test. The tuberculin test has various diameters of induration based on the population. We have an induration of greater than 5 mm for a positive test in HIV patients in close TB contacts as this woman, or if we have chest X-ray evidence of TB. For example, we might have a cavernous lesion at the apices of the lung. An area of induration of greater than 10 millimeters is required for a positive test in homeless patients, in IV drug users, institutionalized patients such as those in penitentiaries, healthcare workers, patients with chronic disease. You will see patients that have either diabetes with renal disease or directly chronic kidney disease, or even cirrhosis. Also, you will have residents of elder care centers and residents of developing nations. For example, in the question stem, you will have a patient that comes from the Soviet Union or from Africa. Also, we can consider a positive PD test that is greater than 15 millimeters in the induration area for patients with no known risk factors. Okay, are there any questions on this subject? Everyone is okay? Okay, so Lucas, Parth, and Dr. Deepak, hope you are all connected, because now we are going to another question. Before, I want to take into consideration the fact that we have to treat a little bit for latent infections. The treatment is either isoniazid for 9 months, or we can use rifampin for 4 months. Latent infections are usually considered the infections with no signs and symptoms. Okay, we have a 6-year-old now that is a child from sub-Saharan Africa, adopted recently by a US family, that comes to the ED. He presents with night sweats, cough and hemoptysis. On the auscultation there are bronchial breath sounds at the apex. Other physical exam findings are remarkable for red tinted hair. On the chest X-ray there is a cavitation of the right lung apex. The PPD returns negative with an induration area of 3 millimeters. What is the reason of the negative PPD test? We have a T-cell immunodeficiency, we have a HIV infection, the patient has kwashiorkor, or the patient is too young and therefore his immune system is not developed enough. Please let me know your answer in the voting poll. It will end in 30 seconds. Okay, let's see the results. So we have an A, a B, and a C. Interesting. So could you explain why you thought A or B or C? That's very, very interesting. Okay, so Dr. Deepak said that the patient has red tinty hair, so he goes with kwashiorkor. Lucas says that kwashiorkor is malnourishment, but he doesn't think that there's any link to TB. Parv, do you have an opinion on this? And also, but PPD negative. Okay, so let's take it apart because this is an interesting question. Now, all four choices can be a cause of a negative test with TB infection. When we think about young age, we think up to actually from 6 months to 12 months, because up to 6 months the IgGs from the mother are still present in the child. So the most susceptible patient of young age is between 6 months to 12 months old to TB. And it would be reasonable to have a negative PPD test. Now let's go to the HIV infection. Indeed, in Africa there are higher rates of HIV infection. However, we have no indication in the question stem that the patient might be suspicious of HIV infection. Usually the HIV infection in a child manifests firstly with respiratory infections or other types of recurrent infections. Here the presentation is of a typical tuberculosis case. Now we remain with A, T-cell immunodeficiency, which indeed is associated with a negative TB, a negative PPD and a positive TB, due to the fact that TB requires cellular component of the immune response, and kwashiorkor, which is malnutrition. Now, if we had a T-cell immunodeficiency, the patient would have other presenting symptoms, such as if he had DiGeorge syndrome, he will come with the catch-22. He will come firstly with hypocalcemia. Also, he will have a cleft lip or cleft palate. Even if he would have Job syndrome, he will present with other infections such as abscesses, Staph aureus abscesses, which are not present. Now, the fact that he had red tinted hair is an indication of kwashiorkor. And why this is important? Malnutrition, especially kwashiorkor, which is based on protein deficiency, leads to decreased immunoglobulins. Immunoglobulins are in fact proteins. Therefore, patients that are malnourished, especially due to protein malnourishment, will develop immunodeficiencies that can mimic, for example, true immunodeficiencies, congenital immunodeficiencies. Therefore, the correct answer is C, kwashiorkor. Let's recap a bit the cases of negative PPD. So a negative tuberculin test can be present in patients that are of old age due to the same factor of immune senescence, meaning that there is less protein synthesis such as immunoglobulins, but due to old age. Malnutrition, as I mentioned before, immunoglobulins are proteins. And congenital immunodeficiencies, especially T-cell dysfunctions. Okay, was this question stem clear? Because I saw a lot of different answers, and I hope that the answer provided you with all the explanation. Please let me know if we have more participants. I see that we have more, apparently, so please let me know your name. Also, thank you, Dr. Deepak, for the compliment. Okay, I propose to go further. Please let me know if you are all joined, and we could go. Okay, if we have any new participants, please let me know your name in the chat box so we can interact actually. Okay, so we have a 20-year-old patient that presents confused at the ED this time. He has petechiae on his abdomen, the blood pressure is 80/50 with 50 beats per minute. There is a 12 respiration rate. His temperature reaches 36 degrees Celsius. On neck flexion, he flexes the thighs. What is the finding on the acid-base panel? We might have an anion gap metabolic acidosis, a non-anion gap metabolic acidosis, a respiratory acidosis, or metabolic acidosis. Please let me know your answer by voting in the poll. The poll will end in 30 seconds. Okay. So we have 2 B's and 1 A. Please let me know in the chat box why you thought B or A. Okay, so Dr. Deepak says that we have meningitis, adrenal hemorrhage, and adrenal insufficiency. Indeed, this patient presents with the classical findings of Waterhouse-Friderichsen complication of a Neisseria meningitis. This usually leads to adrenal failure, and adrenal failure is one of the non-anion gap metabolic acidosis. Now, the next clinical vignette is about a 4-year-old child who comes to the ED with confusion. He vomited blood 2 hours ago. His mother states that she was not at home when this happened. The medical history of the parents are significant for depression in the case of the father and severe menorrhagia in the case of the mother. On the chest x-ray, there are numerous tablets inside the child's stomach. What is the acid-base disequilibrium seen in this patient? Anion gap metabolic acidosis, non-anion gap metabolic acidosis, anion gap metabolic acidosis and respiratory alkalosis, and respiratory acidosis. Before voting, I will warn you that there is another choice that could be true, but is not within the answers. Bonus points are given to the student who identifies a second acid-base disequilibrium that could appear in this patient. So we have 2 votes. Please let me know what do you think the answer is. Because we will finish the poll in 30 seconds. Okay, Lucas. Everyone says A. And Lucas says that we have a salicylate poisoning. Any C? Okay, any other opinions? What happened to this child? And also, what other complications might be? Also, I see that we are once again more students, so please let me know your name to make it enjoyable for everyone. Okay, Parf is on the right path. Indeed, there are iron tablets. So how can we get this GIST? Indeed, the answer is an anion gap metabolic acidosis. Firstly, we have a child that vomited blood. We have the medical history of the parents. The father has depression, but we have no medication that would give hematemesis due to depression, and that is given in depression. But we have the mother who has severe menorrhagia. A mother who has severe menorrhagia is usually prescribed iron tablets to prevent further iron deficiency anemia. Also, it is known that normal doses of iron tablets might be toxic for children. The last detail is the fact that the tablets are radio opaque on the X-ray. This is the only way we can see tablets inside someone's stomach. Regarding what we discussed before about another acid-base disequilibrium that could be seen in this patient might also have metabolic alkalosis with anion gap metabolic acidosis. This can be explained by the fact that he vomited. When he vomits, he will lose hydrogen ions, and there will be a regeneration of bicarbonate leading to metabolic alkalosis. And this could actually, in the clinical scenario, in the real clinical scenario, be a little bit confusing due to the fact that the metabolic acidosis and the metabolic alkalosis will compensate and lead to a normal pH somewhere between 735 and 740. And this could be really a problem that could appear in a real scenario. Now, let's review a little bit what are the causes of metabolic acidosis. As we discussed before, so the first one was non-anion gap metabolic acidosis, and the second one was an anion gap metabolic acidosis. So we have to retain two mnemonics out of this discussion. So for anion gap metabolic acidosis, we have mud piles, meaning methanol, uremia, diabetic ketoacidosis, propylene glycol, iron and isoniazide, lactate, ethanol, salicylates. Usually the clinical scenarios are either someone who has an alcohol dependence and drinks methanol and or propylene glycol, or even ethanol itself. However, or ethylene glycol, we can differentiate between them by the next aspect. An intoxication with methanol leads to blindness due to toxicity to retina. An intoxication with ethylene glycol will lead to crystalluria, namely calcium oxalate. And propylene glycol has the same aspect as ethylene glycol, but is usually rarer. Uremia. Uremia will have patients that have CKD most frequently. Diabetic ketoacidosis are most frequently seen in younger patients that have diabetes type 1 and is their first episode. For iron tablets, we have the clinical scenario of the child who ingests iron tablets, and for isoniazide, we have a patient that is treated for TB. Patients with high lactate will be either patients that suffered burns or that were suffering trauma, such as they have rhabdomyolysis associated with it on the urine analysis. We see myoglobinuria, and salicylates again in suicidal attempts. Now, after we discuss the clinical scenarios for anion gap metabolic acidosis and the mnemonic, we have to consider the non-anion gap metabolic acidosis causes. We can retain them by HARDEST. HARDEST is hyperphagia, Addison disease or adrenal insufficiency as we've seen previously, renal tubular acidosis, diarrhea, astazolamide, saline infusion, and spironolactone. I will not go through each clinical scenario that is typically seen on USMLE because these ones are rarer. However, I have to make a point on a specific question stem that is extremely rare but can be seen and is trickier to see. Namely, you will have a patient that walks on the mountain, and you'll have the detail that he's treated for his feeling of shortness of breath. Namely, he has altitude sickness, and he is treated with acetazolamide, and then he will complicate further down the line, and they will ask you what type of acid-base disequilibrium he has, and you have to think, okay, acetazolamide, non-anion gap metabolic acidosis. Okay, hoping that this was clear. Please let me know if you have any questions. Okay, from Dr. Deepak, we have another proposal of mnemonic, namely fused cars. If you want to use that one, you can check the chat. Okay, please let me know if you have any questions, then we can go further to new questions. As you saw, there are more questions per session, namely more than 4 as usual. Okay. Now, for our little intermezzo, I can tell you that I opened a Patreon page if you'd like to support the work I do. I have there actually the Patreon page has 3 tiers. The first tier will be constituted by week community where you can put all your questions, especially USMLE related question stems, and once per week I will enter the chat and I will answer all of the week's questions. This would help you more in the fact that it will help precisely you. For the last year, I chose to do a monthly live stream with tips and tricks that could give you actually the edge at the exam. And also you could access these live streams in recorded format in the mid tier. The advantages of participating in the monthly live stream is that you can actually interact and put questions. For example, if I use this technique, how could I tweak it for my advantage, and then I could actually respond promptly. I will let the link in the chat box if you want to help and support the work that is done. You can become a patron. If not, you can enjoy the live stream anyway. And for those of you who didn't check the live streams or who checked the live streams without the timestamps, now you have the chance to jump through the questions and answer them promptly, and also you can jump directly to the recap do the review portion that will help you just to review the information rapidly. Okay. Let's go to the next question. And let's talk vaccines. We have a 39-year-old which comes with a hand laceration after trying to mount an old fence. His medical record shows his last toxoid vaccine was at 31 years old. What is the best next step? We administer tetanus, immunoglobulin and TDAP, we administer TD, or we do not give any post-exposure prophylaxis. Please let me know your answers by voting in the poll. Okay, so we have an A and a B. Why A and why B? Let's think about them. So, in the case of administering, the answer is administer tetanus, a TD. Why we do not administer an immunoglobulin? So, this patient has more than 7 years from his last shot. However, he had his shots since he actually did them by 31 years old. I will further explain it after the next clinical vignette. Now we have a 12-month-old who comes to the primary care physician for his vaccination appointment. Which vaccine is the first dose for him? The MMR, the HIB, the poliovirus, the DTAP, the pneumococcal conjugate, or Hep B? Please let me know your answer in the voting poll. Okay, so we have a D and an E. Interesting. The correct answer is measles, mumps, rubella. Haemophilus influenza type B, poliovirus, DTAP, and pneumococcal conjugate are given at 2 months, whereas Hep B is given at birth. As you can see, the answers are B and I. So let's talk about the tetanus post-exposure prophylaxis, because we had different answers here. This patient, the patient that we had a clean and minor wound because it was in a fence, no dirty wounds. So wait a moment. Sorry, it was not a clean and minor wound. He had wound in a fence that gives us this part, the left part of the scheme, which says that in the case of the last TD more than 5 years, we give TD or TDAP. We exclude that he has less than 3 lifetime vaccinations because we were told that he already had those vaccinations. And also we know from the vaccination schedule that they are given by adolescents, all of them. So we cannot give TD plus immunoglobulin. And otherwise we do not give no post-exposure prophylaxis. So for example, if the patient has less than 5 years from the last TD. In the case of clean minor wound, this is not the case of a fence wound. This is the case, for example, of a nail, but a clean nail in the question stem. We will have either the detail that the patient has less than 3 tetanus shots or the last toxoid was at more than 10 years, and then we administer TD or TDAP, or if he has not, the 3 tetanus shots, we will give no post-exposure prophylaxis. Okay, now let's go a little bit deeper and talk about the vaccination scheduling. Now, I will show you the FDA vaccination scheduling that is sometimes required for the USMLEs, but you can learn them very intuitively by learning this. Haemophilus influenza type B, poliovirus, pneumococcal conjugate, and rotavirus start to be given at 2 months. Hep B is given at birth, and measles, mumps, rubella, varicella zoster, and Hep A are given at 2 months. Sorry, I think that I wrote it wrongly. Yes, they are given, as you can see, at 12-15 months. Typo. Like this. Okay, this is the scheduling that is sometimes required, but as I told you, you want to know just orientatively. Rotavirus, DTaP, Haemophilus influenza, PC, and poliovirus. First dose at 2 months. They are usually 3 or 4 doses. The exception is DTaP, which requires 5 doses and by 6 years is finished. The Hep B requires also 3 doses, and also in the measles, mumps, rubella, varicella, and hepatitis, they are 2 doses. Also, you can have the question about Neisseria vaccine. So in the case of Neisseria, when he enters call activity, namely he goes to college, and the HPV vaccination, which is when the female starts to have sexual activity, also somewhere between 13 to 15 years old, when she has already the first menstruation. Please let me know if you have any questions in the chat box. Okay, so we are 4 now. So is Parth again with us? We are 5 actually. Please let me know your names in the chat box, because if you participate, it would be really not useful to just watch. So Dr. Deepak says that he was confused between A and D. Oh yes, D was DTaP. Okay. 9 months measles, mumps, rubella. No. Okay. No. For no vaccination is adjusted for weight or age. This is another question that is typically seen on USMLE. For example, you are told that the child did not attended his second vaccination, and then they quiz you on if you should start again from the first dose, or if you should continue with the second dose. And then they put 4 choices: first dose adjusted to weight or adjusted to age, first dose not adjusted to weight or not adjusted to age, and then you have the choices second dose adjusted to weight or adjusted to age, and not adjusted to weight and not adjusted to age. The idea is that you want to take the answer that states that you continue the vaccination with the second dose, even if he missed that one, with no adjustment for weight or age. This is strongly important because if you think about it, it makes sense. You need a vaccine that is given to form the immunoglobulins. It is not dependent on the dose or the weight to have an immune response to the inactivated virus, for example. Okay, please let me know if you understood these types of questions. Oh, now I got what you said. Yes. Indeed, if the weight is greater than 2 kilos. Right. No. I thought that you said like we adjust for how it's called. Like you increase or decrease the dose based on his weight. Okay. The last clinical vignette of the day. On post-operative day 2, a patient develops EKG changes that show peaked T waves, prolonged QRSs, and wide P waves. On labs, the patient has a potassium level of 7.5 milliequivalents per liter. On urine analysis, there are no pathologic findings. The patient is on an ACE inhibitor due to his hypertension. His serum aldosterone levels are low. What medication caused his symptoms? Warfarin, low molecular weight heparin, aspirin, or acetaminophen? Please let me know your answers in the poll. So we have an A and a D. Do we have any other answer from someone else? I see that our number fluctuates and that we have more participants, but they do not engage with us. Okay, so someone said warfarin and someone said acetaminophen. Can you explain the rationale behind it, and then we can compare the answer and the rationale behind it with the rationale that you developed? Just picked random. Okay. So Dr. Deepak chose randomly. Do we have any other rationales behind it? Please, if you are present, engage with us and write in the chat box. Okay, so someone picked, Dr. Deepak picked A. So let's see how the rationale goes here. Please pay attention to this. Yes, Lucas is right. Is RTA. Due to COX inhibition. So this question has multiple correct answers, but we have to think in context. The answer is B, and indeed someone said aspirin, so NSAIDs. But the thing is that although the NSAIDs can cause renal tubular acidosis type 4, as in this case because we have low aldosterone and also aldosterone resistance, this patient has no indication for aspirin. He had an operation, but that's all we know, so he has no indication for this. However, heparin is used postoperatively to avoid venous thromboembolism. So it is clear that the patient was under LMWH. So let's talk a bit about RTA type 4. It is caused by aldosterone deficiency or resistance. The serum potassium is high, and this is what caused the peaked T waves, the prolonged P waves, the prolonged QRSs. Okay, the etiology, indeed, we can have NSAIDs, we can have heparin or low molecular weight heparin. The patient already was on an ACE inhibitor, so this is the interaction between the ACE inhibitors as well as heparin led to RTA type 4. We can have clinical vignettes when the patient is diabetic, and this leads to aldosterone deficiency, or we can have primary adrenal insufficiency, or as in the case that we saw previously, we can have Neisseria meningitis that leads to Waterhouse-Friderichsen syndrome, that leads to adrenal insufficiency and leads to RTA type 4. Another etiology that can be seen is in transplanted patients that are given calcineurin inhibitors, such as cyclosporin or tacrolimus. You can have patients that develop RTA type 4. Usually we talk about kidney transplant. So how can we treat this patient? If we are asked how do we treat the patient, we give them sodium bicarbonate, we give them potassium wasting diuretics, we give them mineralocorticosteroid supplementation. Okay, please let me know if you have any questions on the topics that we covered today. Okay, thank you also, Dr. Deepak. I hope I provide value to you. If you think so, please recommend me to, and not me, please recommend the live streams to other students that might benefit from this value. If you also consider that this brings value consider donating on Patreon. This helps me put out these videos, as well as improving their quality and getting more technology involved so that we can develop better live streams as well as videos. So yes, it would be great if you can bring new participants. Now, if you didn't complete the form for the feedback, please consider completing it. It helps to, again, improve the live stream as well as other videos. I will also mention the fact that starting let me be precise, starting 30th May, I will try to do a 30-day challenge. Actually, no, I will do a 30-day challenge with at least 3 videos per week, 2 educational videos and 1 live stream. If you are already in the newsletter, let me know what topics you have difficulties with, because that month will be extremely focused on the topics that you have most difficulties with. Okay, please let me know if you have any suggestions now in the chat box. Consider donating on the Patreon, consider recommending the channel and subscribing, and that's it. Okay, so I wish you a nice weekend, and see you on the next live stream on 4th of June. Bye.